In this recording, we're going to discuss therapy-induced immune deficiencies, not including HIV. So, therapy-induced immune deficiencies are going to be deficiencies of the immune system that are secondary to some sort of treatment generally. Acquired secondary immune deficiencies are related to those other conditions that cause the loss of immunoglobulins or antibodies. They might destroy lymphocytes, and usually, like I said, these are going to be treatments or drugs. Acquired secondary immune deficiencies are going to be those loss of immunoglobulins or lymphocytes. Sometimes we want someone to be immunosuppressed, and that is actually the desired outcome of those treatments. We are giving people those treatments so they lose the lymphocytes or the use of their immunoglobulins. This would be like an organ transplantation, or if we're treating an autoimmune disorder. Unfortunately, this also could occur because of something like chemotherapy, which would make immunosuppression an undesired effect and put people at risk for greater complications. So what we want is to have the maximum therapeutic effect without leaving someone overly susceptible to complications like infection. So we've got those drug-induced or therapy-induced immune deficiencies. Cytotoxic drugs are going to be generally used to treat cancers and other autoimmune disorders. They interfere with cells that are rapidly dividing, hence cancer cells, especially white blood cells as well. So the result obviously is going to be a decrease in those white blood cells, especially neutrophils. That is going to increase someone's risk for infection. Cytotoxic drugs can also interfere with lymphocytes' ability to produce and release cytokines and antibodies. We're going to talk about corticosteroids in greater depth in the next slide. Cyclosporin is going to be suppressive of the CD4 T cells and often is used to prevent organ transplant rejection and also against some autoimmune disorders. So corticosteroids are a tough one because they generally make relatively healthy people feel really good because they are anti-inflammatories. They take away even the smallest inflammation, making people, their joints feel good. But look at the list of possible adverse reactions and difficulties that people can have with corticosteroids. So corticosteroids are hormones with anti-inflammatory and immunosuppressive effects. They're generally used to treat those autoimmune diseases, neoplasms, like cancers. Neoplasms are cancers, and some endocrine disorders. They inhibit inflammation by blocking the movement of white blood cells, and they work as well on that arachidonic acid pathway, and that's, remember, where NSAIDs work too. Corticosteroids reduce T cells, resulting in suppressed cell-mediated immunity, and they're also going to interfere with immunoglobulin G production. They reduce antibody-antigen binding. And like I said, pay attention to this list and then in your book as well. In the 8th edition of Iggy, it's page 345. In McKinney's 4th edition, it's 1054. In the 5th edition, it's 946. and there's some good side effects and other information on corticosteroids in there. So when someone is on corticosteroids, they're likely to cause GI distress, so make sure that they're taking it with food. On the slide it says avoid live vaccines in children, but that's also going to be adults, as the shingles vaccine is a live attenuated vaccine. In children, that's going to be like the MMR and the varicella vaccine. I have listed on here some of the adverse reactions that people might see. So we're going to see potential Cushingoid state, so that moon face or the buffalo hump, delayed wound healing, skin eruptions, fluid retention, potential for delayed growth in children, and the potential for acute renal insufficiency. Usually when we are going to see adrenal insufficiency, usually when we see adrenal insufficiency, it's going to occur if a patient has been on long-term steroids and is abruptly taken off of them, or if someone is under significant stress. Some other possible complications of corticosteroid therapy that I don't have on the slide are going to be hypertension, loss of muscle mass, amenorrhea or no period, osteoporosis. This is going to be especially important for people who are on lifelong steroid therapy. We have to remind them to be taking a calcium and vitamin D supplement. People can get cataracts. Topical steroids can cause topical problems like thinning of the skin, those red spider webs that you see on people's cheeks. Then we also can, we might see radiation-induced immune deficiencies. While it's not as significant as chemotherapy, radiation is still toxic, especially to lymphocytes and neutrophils. If you think, especially where are those white blood cells produced, and all blood cells for that matter, most blood cells are produced in the bone marrow. So radiation to the ileum and the femur are the primary blood cell producing sites. Any radiation to those two areas can cause generalized immune suppression, which is a real problem. So for these folks who are having radiation, we're going to want to, well, for anyone with immune deficiencies, our goal is going to be to improve their immune function and prevent infection. With these folks who are getting radiation or maybe have immune deficiencies that cause decreased blood cell production, they might receive like hematopoietic growth factors, like Epigen, I'm sure you guys have seen or heard of. That's going to be something that's going to help stimulate the bone marrow into producing more immune cells. So this was just a quick add-on lecture to the HIV lecture that you'll be getting in class.